You can all see my screen, correct?
Yes, sir.
Okay. So, we are going to move on from our skeletal lecture last night, or last week, boy. It was a quick week. I don't know about you, it's a very quick week for me, and I don't really know why. But we are going to. Last week we talked about skeletal system. This week we are going to talk about articulations or joints. Now, I'm going to ask you a question, introductory question. I want you to keep in mind that we live in Florida. We do not live in California or Colorado or Michigan or I can't think of other states. But keeping that in mind, where we live, what is the first thing that comes to mind when you think of joints?
Joint pain.
Joint pain, boy, that's a very pessimistic thing to come to mind. uh, when you picture a joint, what do you picture?
A little ball.
A little ball? Can you?
Not like a ball. I mean, a joint. Like yes, like she said, an elbow, but like it's between two long bones. That's what I think of as a joint, like a ball between. Bad at explaining, but
Yeah, no, you're fine. And I like the fact that you said between two long bones because something like an elbow or a knee or the knuckles, things like that, things that we picture as joints really are joints between long bones. And what we're going to talk about today is the fact that there are a lot of other types of joints. A joint is anything that connects two bones together. And so it doesn't have to be this type of a joint. Now, if any of you are curious about the other type of joint, what you need to do is you need to get a bachelor's degree, and then you need to apply for my non-degree status at UF, and you can take my pharmacology of cannabis, tobacco, and vaping course. I would love to see you there. So, like I said, a joint is anywhere where two bones come together, and that is the definition. An articulation is simply a more technical term for a joint. But in my mind, a joint is actually a more descriptive word because when I think of articulation, I think of the verb articulate, which means has at least involves moving. And like we're going to see, not all joints are movable. There's an entire class of joints. Now that there aren't a whole lot of examples that fall into this class of joint, but there are joints that are defined as being immovable. And so to my mind, a joint is it doesn't infer movement like the word articulation does. And so because a joint is where two bones come together, it can be acting like glue or it can be to allow mobility. Now, joints in my finger do act to hold my skeleton together because if that joint wasn't there, my finger would just flop over, right? But the fact that it is this type of joint is going to allow some movement. So we have really two different ways to classify joints. And so if you talk about a joint, if you, say you pick a joint in the body, you're going to be able to classify it as one of three types of joint based on the structure of that joint. And you're going to be able to classify it into one of three types based on the function of that joint. There is not a one-to-one correlation between the structural types up top and on the bottom. You can't say that every fibrous joint is a synarthrosis. You can't do that. You take every joint one at a time and say it is this type of joint structurally, it is this type of joint functionally. And so the structural classification has to do with what is the glue that is holding this joint together. So we have fibrous joints cartilaginous joints, and synovial joints. Fibrous joints are joints that are held together by, believe it or not, fibers, and they are, in particularly, they are collagen fibers. So we're going to see these fibrous and collagenous joints later on, but we have fibrous joints, we have cartilaginous joints, which are where we have two bones together, and then there's a piece of cartilage between them. And then we have synovial joints. Synovial joints are the types of joints that you think of when you think of joints. These are these freely movable joints. Now, they are more complicated. Fibrous joints are simply two bones basically tied together by some collagen fibers. Cartilaginous joints are basically just two bones glued together by cartilage. The synovial joints have, there's multiple parts involved here. We can't really talk about this structure until we actually get to them on their own slide. And so every joint in our body is either going to be fibrous, cartilaginous, or synovial. If you look at the function of joints, though, in this case, we are going to classify joints based on how movable they are. There are synarthroses. Synarthroses, this is a plural form of a word. The singular form would be synarthrosis with an IS on the end. This is a joint that is basically immovable, and before we talk about them in more in depth, the best example of a synarthrosis is going to be the sutures holding the skull bones together. Those do not move very well. They're more or less just glue at this point. A freely movable joint is a diarthrosis, and then in the middle we have amphioarthroses. These can move, but they're not freely movable like this. Now, the way I remember which one is which is when I see amphioarthroses, I think of amphibian. What is amphibian? What is an amphibian, or what does amphibious mean? What's an example of an amphibian animal? So you're on the right. You're certainly on the right track. It's not necessarily that something can breathe in water and air. It's that it lives in the water and the air. An example is a frog. A frog is an amphibian. It has to breathe air. It can't breathe in the water, but it is perfectly comfortable on land, and it is perfectly comfortable in the water. Something like a human, we can go in the water, right? We're certainly more comfortable on land. Something like a dolphin can go onto land. I mean, it wouldn't do it on purpose, but if it does, it can still breathe. It's not like a fish, right? Amphioarthroses are in the middle, right? A amphibian is comfortable in both situations. It's kind of a cross between the two. Amphioarthroses are in the middle. This is somewhat movable. It's not freely movable, but it's also not immovable. So that's how I remember that the amphioarthrosis is in the middle. So this is a fibrous joint. There are multiple types of fibrous joints. This is not the only, right? Yeah, okay. This is not the only slide, and this is not the only example of a fibrous joint. And an example of this is the suture joints in our skull. That is these little jagged lines holding the different bones of your skull together. If you did the skeletal system lab, then now you're familiar with these different bones. They're held together by sutures. They are a synarthrosis, meaning they are essentially non-movable. And not only that, as an adult, they are about as non-movable as a joint can be. In a newborn, in a child though, we know that children have soft skulls, right? The bones themselves are not soft. What is soft are the joints between the bones. And so there are these areas, these joints of fibrous connective tissue, the collagen holding these bones in place. And so really all you've done is you've kind of taken some string and you've tied the skull bones in place. There are some what we call fontanelles, which are basically soft spots on the skull, where there's a fairly large space where there isn't a skull bone. We have these thin little lines between the skull bones, but we also have some large spots. Now, the most common one that people are familiar with is the anterior fontanelle, which is kind of on the top of the head towards the front. Now, I want to ask you a question. If the purpose of the skull is to protect the brain, it seems like it'd be pretty important for the skull to be hard. So why is the newborn's skull soft?
To grow?
Yes. So we have other joints in our body. Why would the skull, of all the joints in our body, really need to grow in a newborn? What's in there?
The brain.
The brain, yeah. And so the brain is going to grow very quickly. I mean, that's one of the things that makes young animals, humans included, cute. It is the oversized head compared to the body. And that doesn't go away as soon as someone is born. Kids generally have oversized heads. The brain is going to grow very quickly. When we are born, we need to start picking up skills quickly. And so that brain is going to need to grow quickly. And so the skull is going to need to expand with it. What is another reason you can think of that skull might want to be soft? Yeah, for birth. The squishier that is, the easier it's going to be to get out. It's just no other way to put it. So like I said, that is not the only type of fibrous joint. Another example of a fibrous joint is called a syndesmosis. An example of a syndesmosis is what you're looking at in letter B here. This is the radius and the ulna, the two bones in your forearm. So essentially, what we've done is we've taken the two bones in the forearm and we have tied them together with collagen fibers. So you can see it kind of looks like a spider web holding those two bones together. And so it's movable until those fibers come tight. And so think about taking two sticks and tying them together with string. As long as that string isn't tight, they're freely movable. So really what that joint is doing is it's limiting how far the joint can go. We'll see this later on, but the radius and the ulna actually have some very surprising movements that you probably don't realize are happening. When you turn your arm up and down like this, the radius and ulna actually go from next to each other to crossed, and they get flipped back and forth like that. And so they need to be freely movable to an extent. But you don't want the radius and the ulna floating apart from each other every time you put force on your arm, otherwise it just wouldn't work. The third type of fibrous joint is called a gomphosis. And the example of this is the joint that holds your tooth into your socket. So what you're looking at here is a cross-section of your jaw, and then the tooth is sitting down in the socket. And so they haven't zoomed in far enough for you to see it, but essentially what's going on is where this yellow-orange line is, there are a whole bunch of very small little collagen fibers that simply hold that tooth into place. Why do you think we have collagen here rather than something that would be a little more firm?
Because we lose teeth.
We lose teeth. As a child, we lose teeth, and so it's much easier to just get rid of collagen than it is to get rid of cartilage or bone. But with the sutures in the skull, they start as collagen. As we get older, they actually turn to more or less just solid bone holding them together. Why do you think what's holding the teeth in doesn't just turn to bone? Because if we get hit in the jaw, we will accidentally lose teeth. And if it was glued in there with bone, they'd be less likely to come out. Exactly. Shock absorption. Yeah. The way I think of it, it's kind of like the tooth is embedded in a trampoline. And so when you put some weight on it, it's able to move just a little bit. We can put a surprising amount of force on our teeth. If you've ever been chewing on something or you're chewing on something hard and it slips and your teeth smack on each other, they'll actually chip each other. And so we can take some of that shock absorption or take some of that shock away because it can actually move a little bit. Also, the fact that this is held in by collagen rather than cartilage or bone actually means if we do accidentally knock out a tooth, we can put that tooth back into place and it will reattach because collagen grows pretty quickly. We talked about cartilage, it has no blood vessels, and so cartilage would be very, very slow to heal. And bone also is a pretty slow healing process. But collagen, you can replace that in a week or two. And so if you knock your tooth out, they just put it back in, they kind of glue it in place temporarily, and while it's in there, the collagen reforms and your tooth is back in place. So we're going to move on from our fibrous joints to our cartilaginous joints. And again, we have more than one type of cartilaginous joint, but a cartilaginous joint as a whole just means we have two bones held together by cartilage. One example of a cartilaginous joint is the intervertebral disc. So what you're looking at here in this picture are two spinal vertebrae, one on top, one on the bottom, and then we have a big fat disc of cartilage in between them. And this is fibrocartilage. Remember, we had three different types of cartilage. We had fibrocartilage, we had hyaline cartilage, and we had elastic cartilage. Fibrocartilage was the toughest of the three. It's also the least flexible of the three. And so we put a lot of force on our spine. Every time we walk, every time we jump, all of that force goes on our spine. And so this provides a little bit of shock absorption in this case as well. It also is going to allow for a small amount of movement of our spine. We can't move our spine nearly as much as some other joints in our body, but we can move it some. So this is technically called something called a symphysis. A fibrocartilage joint is called a symphysis. Another example of a symphysis in the body is the pubic symphysis. So you're looking at a pelvis here, and the left and the right side of the pelvis are actually separate bone structures. They wrap around in the front, and then they are held together by fibrocartilage. This again provides some shock absorption. The force comes up our legs into our pelvis, so this allows just a little bit of flexing to go on there. When women are pregnant, the pubic symphysis will actually start to soften up a little bit to allow the birth canal to expand and get a little bit bigger. Another type of cartilaginous joint involves hyaline cartilage. If we have hyaline cartilage, we are called a synchondrosis. Now, there are a few places where we have hyaline cartilage. We saw a little bit last week where we have cartilage on the end of long bones, right? If you have two long bones coming together, there's going to be cartilage on the end of each of those long bones. And that is actually going to be hyaline cartilage. We also have hyaline cartilage at the epiphyseal plate. So remember, when a bone is growing, we have the epiphyseal plate. As an adult, it hardens into the epiphyseal line. When we're a child, we have that hyaline cartilage there. That cartilage is holding the diaphysis and the epiphysis together. It is acting as the glue holding those together. And so that is technically called a synchondrosis. Another example, not shown here, of a synchondrosis where we use hyaline cartilage is on our ribs. A lot of our ribs, the ribs themselves are bone. The sternum that they are connected to is bone. But there's a little bit of hyaline cartilage between the bone part of the rib and the sternum, which allows flexibility again. If we get hit in the chest, we want those ribs to flex rather than break. Also, every time we take a breath, our chest needs to expand a little bit. So having that hyaline cartilage there allows the ribs to flex just a little bit and give the lungs extra room to expand. So going back a few slides, 3 types of joints based on their structure. What were the 3 types? C. That is the correct answer. Fibrous, cartilaginous, and synovial. What type of fibers were in the fibrous joint?
Collagen fibers.
Collagen fibers, yes. So we talked about fibers, we talked about cartilaginous, we have not talked about synovial joint. And that's because, like I said, they're much more complicated. We're going to talk as much about synovial joints as we did about the other 2 combined, if not more. So when we look at a synovial joint, there are 5 primary parts, and we'll see those on this next slide. But it's going to be the articular cartilage, which is the cartilage, the hyaline cartilage on the end of the long bones that are coming together to form the synovial joint. There's going to be an articular capsule, which is going to be a membrane surrounding the synovial joint, holding everything in place. The area inside that articular capsule, in between the bones, is going to be the synovial cavity. The synovial cavity is going to be filled with synovial fluid, which is basically a lubricant between the bones. And then there are going to be ligaments helping hold this in place, because this is going to be a very movable joint, and we don't want everything just flopping around uncontrollably. So this is that synovial joint. We have 2 long bones coming together, one on the top, one on the bottom. Each of those has a layer of articular cartilage on their end. We have a articular capsule on the outside, so basically connecting the 2 bones together on the outside, but notice that the bones don't actually touch each other. There's this open area. That open area is where the synovial fluid is going to be. That synovial fluid is made by the synovial membrane. So that synovial membrane is on the inside of that articular capsule. There's some cells there that, kind of like the cells that make the cerebrospinal fluid, are going to make the synovial fluid. And so what we have here is we have 2 bones that are right next to each other. that are connected by this flexible articular capsule, and that area in between the bones is filled with a lubricant. And so I hope you can see that, and remember that the capsule on the left and the right here is flexible. It's kind of like a water balloon that these bones are in. And so these bones can very easily just flop all around. It's going to be freely movable. And it's freely movable because they don't actually touch each other. There's nothing to stop that movement. So what do you think the purpose of this articular cartilage is? I mean, the bones don't touch each other. And so why put that cartilage there? Any ideas? Imagine I put a bunch of... Imagine this is a leg in the leg. Yeah, there you go. To protect if they accidentally touch. If all that's keeping those bones apart is some water, basically. If you put some force on that, they're going to compress, and those bones are going to touch each other. And if they touch each other, you don't want bone on bone. Bone is rough. And so if you have bone on bone, it's going to be like sandpaper. They're going to destroy each other, and it's going to be very, very painful. This articular cartilage is hyaline cartilage, which is very glassy. It's smooth, it's slippery, and so they just slide over each other. One problem that we get is osteoarthritis. Osteoarthritis is arthritis that is due to basically just wear and tear of joints. That is in contrast to rheumatoid arthritis, where our immune system is actually attacking our joints. They are completely, they have a lot of the same symptoms, but they are completely different diseases. Osteoarthritis is just wear or tear. And so in osteoarthritis, essentially, this cartilage has worn away. And now we have bone on bone, which is why it can get so painful to have osteoarthritis. Not pictured here are some ligaments. Now I said, you look at that and you can clearly see that that should just flop all over the place as needed. But we know that joints don't just flop all over the place, right? A joint generally has a limited range of motion. They can go this way, it can go that way, and it can only go so far. That is a lot of times dictated by the ligaments. So the ligaments will let that joint move, but then the ligament comes tight and said, no, I'm not going to let you go any farther. So looking at the synovial joint and classifying it based on the amount of movement, is it diarthrotic, amphiarthrotic, or synarthrotic? So I got an A and I got a B. So the correct answer is diarthrotic, but I actually like the fact that you said B, because I just got done talking about how it can move so far and then stop. I'm thinking that's what your thought process was. So we don't have any joints that are freely movable with no end. And so the most freely movable joint that we have is a synovial joint. The joint itself is freely movable. It is the ligament that stops it, whereas the amphiarthrotic joints or the synarthrotic joints, the joint itself is not freely movable. So what are these things that keep these diarthroses, these synovial joints, from being really completely freely movable? Number one, we're going to have what we call articular surfaces. So, but not all the bones are going to look like that. We're going to have joints made of bones that have different shapes. And so the shape of the bone is actually going to limit how far that joint can move. It's going to move, but then the design of that joint is going to cause the two bones to run into each other and not be able to move any farther. So that's the articular surfaces. What is the shape of the surface where those bones come together. That's going to influence how quickly or how far that can move. It's actually and also going to hold those joints into place. And we'll see that when we start to see some more examples of actual joints. Like we said, we're going to have ligaments that limit the range of motion and also are going to keep it from being just flippity floppity. It's going to give it some structure so that when we stand up, our knees don't just buckle to the side. Muscles also do the same thing. Athletes work very hard to strengthen their muscles, like in their ankles and their knees, in order to prevent blowing out or twisting their ankles and their knees. Very strong muscles in those joints will resist the force on that joint, helping keep the joint in place and preventing them from tearing that joint. So here we see some examples. This is your hip. So we have the top of the femur coming into the hip. And so you can see that the way this fits together, number one, we're going to be limited in the range of motion. If you take this leg and you start to rotate it all the way up, this bump is going to hit here and prevent that leg from going any further. Same thing with you if you go any other direction. You can also see that the pelvis kind of cups it a little bit, helping to hold it in place. So that's going to help provide some stability. That whole joint is also wrapped in ligaments. And so if you try to bend that leg backwards, these ligaments in front are going to come tight and prevent it from going any further. It's also going to help hold that leg in place when we put force on that leg. So it's going to keep this little head of the femur inside the pocket and prevent it from just popping out and floating away. This is a knee. So this is your knee that you're looking at it from the front. It's an anterior view. So if you look at the knee, you'll see this more in detail in the lab. There are a number of ligaments that are holding it in place. And these are ligaments that you are familiar with by name. Remember, you've probably heard of the ACL, right? And the MCL, the PCL, these are different ligaments. Imagine this knee that is not being pushed from the side. It's straight up and down. We're going to have ligaments inside that knee holding things together. And then we're going to have ligaments on the side also holding them together. In this picture, what we've done is we've put sideways force on that knee. The knee is designed to go front and back. If you put sideways force there, that is not designed to move that way. And so when you put sideways force, you can see it wants to pull the other side of the knee apart, which causes these ligaments to tear. And so I'm sure you've heard of people tearing their ACL. That is exactly what's going on here. The ACL is this ligament right here. There's also a PCL, a posterior cruciate ligament, that's in the back. It's not shown here, but it's essentially the same thing. You'll see that in the lab. There are also the medial and lateral meniscus. These are two little cups on the bottom of the knee. And you can see where this bump here would fit into that cup. That bump would fit into that cup. And those cups help hold the knee in place. You also hear people tearing their meniscus. And so, if you put sideways force on this knee like this, you're going to put force on this edge of that meniscus, and on its way out, you may put some force on this edge of that meniscus, and it's going to tear. Or imagine if you put kind of a downward diagonal force. It's going to want to cause these to push hard down onto each other and then slip. And so you're going to force these bumps deep down into those little cups, these little bowls, and then bust out the side. So you're going to tear that meniscus. So we have a number of different mechanisms of reducing the amount of friction that occurs in our joints. The meniscus is one. That meniscus is made out of hyaline cartilage, which again, remember, is very glassy, it's very smooth and slippery. And so when the two bones do actually come together, it's slippery on slippery and there's basically no friction. We also have two things that they're a little more difficult to picture. There's an image on the next slide that we'll try. But these are bursas and tendon sheaths. So a bursa is basically a little water balloon. And so we're looking at the knee again. This time we're looking at it from the side. We have the femur here, which is your thigh bone. You have the tibia, which is part of your lower leg. And then we have a kneecap. And we have a tendon here. You see this tendon? We have also have a muscle from the quads up here attached to that tendon. If this bursa was not here, that tendon, that muscle would be directly on that bone. And every time that bone moved, it would rub on the tendon and the muscle, which would create friction. And so what we did is we take basically a water balloon, which is the bursa, and we put it between the bone and the tendon and muscle, so that they're not actually rubbing on each other. So bursa with an E on the end is the plural form. A tendon sheath is similar to a bursa, but rather than being a simple water balloon that you kind of stick in a strategic place, it's more complicated. It's like a water balloon in the form of a tube. I don't know if you've ever seen the little weird plastic tubes filled with water where you put it in your hand and you kind of shake it and it jiggles back and forth, but that's basically what it is. Imagine a hose where the wall of the hose was somehow filled with water. And then you had a tendon running through that hose. That would be a tendon sheath. And we have some of those on the tendons on the back of your hand. You probably can't see it, but if you look at the back of your hand, you wiggle your fingers, you can see the tendons on the back of your hand. They are resting on top of your hand bones. And so every time you wiggled your fingers, and you can see those tendons moving, there would be a lot of friction there. And so we wrap them in tendon sheaths in order to reduce that friction. So this is just another picture of the knee joint, and here you can really see the lateral and medial meniscus. There's no new information on that slide. So looking back at our synovial joint, what made the synovial fluid?
The synovial membrane.
Yes. That's why it's called the synovial membrane, because it's a membrane that makes synovial fluid. What slide are we on? We're moving right along. 19. So I think we have 5 slides left. I think we'll just keep going. We'll skip a break today. We'll just finish and be done. So the last thing we need to talk about is movements. And so we talked about the joints. Different joints have different ranges of movement. They have different types of movement. So here we're going to look at the different types of movement that we can get from synovial joints. And each type of movement has its own name. You are going to want to remember these names of the movements, what the movement is, and be able to give an example of where in the body that type of movement happens. And in a lot of cases, these are going to be in pairs, because a lot of joints can move in two directions. And so we're going to give one name to one direction, one name to the opposite. The first pair is flexion and extension. Now, in this drawing here, they show bending the knee and they show moving the shoulder. The best example, the one that you're going to remember, is actually movement of the elbow. Now, the elbow and the knee are basically the same joint, just one's in the arm and one's in the leg. And so more or less they're showing this. But the reason I say you're going to remember the arm is because what do you do when if somebody said flex your muscles, what are you going to do? You're going to do this, right? You are flexing your elbow. When you have a joint, and it can move two directions. My elbow cannot move this way, at least not without causing extreme pain. It moves this way and it moves that way. When you move that joint, the direction that it is able to move more naturally. So if I imagine I am in the anatomical position, my arms are stretched outwards. I can't move my elbows backwards. The natural way for them to move is this way. So that is flexion. The opposite of that is extension. So extension is, think of it as kind of moving back towards the anatomical position. We can also apply this to our neck. And in the picture they show flexion is moving forward. So think of if you were in the anatomical position with your neck straight up, it's more natural to move your neck down, to touch your chin to your chest, than it is to move your neck backwards. And so flexion is going to be down, extension is going to be back. Now, a term that you've probably heard is hyperextension. When we hyperextend a joint, that is going beyond the anatomical position. And so my elbow cannot hyperextend, at least again without causing extreme pain. Some people we use the term double jointed, which does not mean they have two joints. It's just, I don't know, honestly don't know where that name came from. But they have more flexible joints. They may actually be able to move their elbow back past the straight point. That would be hyperextension. For most of us, though, when we are hyperextending our elbow or our knee or our ankle or whatever it may be, it's because some sort of external force got applied to it. We got hit or something and caused that joint to move further than it would normally move. And when that happens, those ligaments in the cartilage and things start to tear. So that's flexion and extension. Another pair of terms is adduction and abduction. Abduction is any movement that is going to take the part of the body further away from the midline. So they show abduction if you're in the anatomical position. If you just raise your arm to the side, you're taking your hand further away from the midline. That is abduction. Adduction is the opposite. It's taking it back towards the midline. The way I normally suggest people remember which one is which is if someone gets abducted, they get taken away. Another type of movement is rotation. We have a rotation is going to be if you put a line down a bone and it spins around that line. You can see my arm. If you drew a line straight down my arm, my arm never leaves that line. It simply rotates around the line. If something is rotating towards the outside, we call that lateral rotation. If we rotate towards the midline, that is going to be medial rotation. And notice that they talked about lateral and medial rotation for the leg, but for the neck, they didn't. Why do you think for the neck they did not define lateral versus medial rotation?
Because you can't turn your head inward or outward.
Yes, because it is already on the midline. A knee is off the midline. And so if you rotate your leg, that knee is going to move either towards the midline or away from the midline. So we can say lateral or medial. But for the head, it doesn't matter. Any movement is actually going to take at least the front of your head away from the midline. Next, we come back to this that I was talking about before with the radius and the ulna crossing each other. This is called supination and pronation. Supination is when your palm is up. Pronation is when your palm is down. And you can see in the picture that when the arm is pronating, the radius and the ulna are actually cross each other. When it is supinated, they are parallel to each other. The way I suggest remembering which one is which is if you are going to carry a bowl of soup, you would carry it like that. Assuming you had some sort of a hot pad or something, or you like cold soup. In reality, when I carry soup, I very, very dangerously carry it with the tips of my fingers gripping the edge of the bowl, right? So remember, think of holding soup like this, not this way. So next we have dorsiflexion and plantar flexion. This is the movement of your foot up and down. Think about when you're like hitting the gas and the brake pedal. So plantar flexion is when you put your foot down. Dorsiflexion is when you put it up. The way I suggest remembering this is remember the plantar region is the bottom of your foot. And the bottom of your foot is down. And so if you move your foot down, it's kind of moving towards the plantar region. That's the way I remember it. Our ankle can also tilt sideways. If it tilts towards the midline, it is inversion. If it tilts away from the midline, it is eversion. So depending on whether you're talking about the left foot or the right foot, they might bend opposite directions. So if I invert my right ankle, it goes towards the midline, and it actually goes towards the left. If I invert my left ankle, it goes towards the midline, but it's actually going to the right. And so they're opposite for the left and the right side. We have protraction and retraction. Protraction is jutting outwards. Retraction is going backwards. Elevation and depression. Elevation is going up. Depression is going down. That's probably the easiest one. Opposition is moving two things together. We like to say that we have opposable thumbs, right? Because it can oppose their other fingers. My other finger, these fingers are not opposable because I can't get them palm to palm. And so we have different types of synovial joints. Each one is going to allow different types of these movements. And we have 6 primary types of these synovial joints. The first is a pivot joint. And you can see a picture here. Essentially what it is a rod stuck through a hole, and that rod can spin in that hole. And so all it's going to allow is spinning. It's not going to move like this. It's just going to be spinning. And the best example they're giving here is between C1 and C2 vertebra, the atlas and the axis. This is the dens sticking up into C1. So if you haven't done the joints, I guess that was a skeletal lecture, so you are familiar with that. Next is the hinge joint. This is basically a barrel sitting in a cut open barrel. And so you can see this fits down into this little groove, but you can also see that it's only going to move so far until this long bone that sticks up this way is going to come around and hit the side of the cut barrel. So it can go one direction, it cannot go this way, right? It goes this way only, and only so far. Then we have a saddle joint, which is kind of like if taking two U's and put them together. It can go like this, and it can go like that. A plane joint is where you have two flat things that are basically just going to slide up against each other. These are in our ankle and our wrist. A condyloid joint is kind of like a cup it's kind of, boy, I don't know how to put it in words better than if you look at it, you can see it's kind of a round structure sat in a cup with the other half of the cup here. And so it can move a little bit. It's kind of like if you've ever seen a golf ball where there's the inner part of the golf ball and then a hard shell on the outside. And if you cut just the hard shell and you had half the hard shell and the bump of the middle here, and you took the rest of the shell and set it on top, it could kind of move a little bit. And then finally we have the ball and socket joint. This is the most movable joint in the body. We have a cup and we have a ball that fits into it, and it can move every single direction. This is our shoulders and our hips. This is an example of that pivot joint where you're looking at the atlas, and this is the dens sticking up from the axis into this little hole, and so you can see how that's going to spin. And that is what allows my head to spin. When I turn my head, the vertebrae down below C1 and C2 are all twisting a little bit, but the majority of that comes from this dens spinning in that little hole. That's why my neck or my head is much more turnable than anywhere else in my spine. So, what type of joint was in your elbow? Do you remember? There's a few slides back. It'll show you if you forgot. So I think that answer is a new one. There's no timestamp on that text. But if we go back, the elbow, it shows, was a hinge joint, which is B. So that is the end of our joints lecture. We only have one left, and so we'll do the muscles next week. That's going to be a longer one than this one, certainly. And we'll do some review before, we'll do some review after that to kind of make up for this short week. Do you have any questions before we go? Okay. So if not, that is it. You are done for the day. My suggestion is do the joints lab. Don't put it off. Get it done. It's a quick one. Just get it done. Let's keep the final exam in mind. Do some studying. Fill out the study guide. Do the extra credit. And let's keep on track for the rest of the semester. So if you do come up with questions, email me. Otherwise, I hope you have a good night.